Revolutionary talk for revolutionary times. Promoting peace, liberty, and prosperity around the clock. LibertyTalk.fm.
Welcome to Medicine on Call, where it's all about living the solutions. Today I'm going to have a good friend on who I haven't had on in quite a while, but I think it's time with all the changes that are happening in our healthcare system to have Mr. Ralph Weber on. He is the CEO and I think founder of MediBid, which is a novel and important service where patients and doctors can bypass the middlemen, make deals with each other, and actually provide service that's cost effective, price transparent, and I believe this should be the future of our healthcare system. So Ralph, I know you're so busy and I'm really, really blessed to have you back on. I saw you a few weeks back at a conference and it was so nice to reconnect with you.
Yeah, it was great seeing you as well. That was an interesting conference, and I always meet, good friends at those, and it's fun to reunite and find out what we're all doing. We're all so busy, so it's great seeing you.
Exactly. And I remember a few years back when I had you on, for full transparency, I'm also a member of MediBid. I really love the idea that I, as a physician, could set my price and find a patient who was willing to pay it and work together to find the best value. And no one felt like they were getting gouged, but they felt like they were getting value for the service. And I know it's grown so much since then. So I want to give you the opportunity to first let us know a little bit about you and how you got MediBid started.
Okay. Well, I started MediBid. We started working on the concept in 2009. We opened to the public January 1st, 2010. Our initial idea was to target people with high deductible health plans, health savings accounts, people that were uninsured, Canadians on waiting lists. Those were some of our initial markets. But as we grew, the last, I would say, 2.5 years, we've really focused on the employer market, where a company with, 50, we've even got some with only 25 employees to as many as 80,000, want something that, as you mentioned, cuts out the middleman, restores the doctor-patient relationship, reduces costs, and they put that in place of the preferred provider network, which they take out. The preferred provider network, as you know, managed care has been around since 1973 when the HMO Act passed under President Nixon. And it's really morphed to the point where it's a huge burden on employers because of the increases in costs. There's shrouds of secrecy and there's gag clauses and all kinds of things in a PPO network. Recently, a couple of the very, very large carriers have been sued in the state of Michigan and the state of Illinois just for this reason, for, saying that the provider billed $100,000 and we paid them $50,000, and then it was found out that they actually paid them less and sort of, skimmed some money off of there. So there are lawsuits like that are happening. Mm-hmm. There are some that are going to continue to happen. So we wanted something that was more pure, that puts the doctor and the patient together again, because, you and I, of course, remember back in the days of Dr. Marcus Welby, those types of shows where you had that direct relationship, which the insurance companies have gotten in between.
You said something that I really want to highlight, because I found this out myself. I really didn't know how this system worked, but it's just a setup to gouge people. You mentioned that the insurance companies and these, basically insurance companies, when they work with employers, they try to sell themselves as a method of saving money. Is that a fair way to say it? And they get paid based on how much they save you. Is that how it works? Because I really want to highlight that, because it's wrong if that's the way it works.
Well, the insurance companies try to demonstrate that they save you money, mm-hmm. but it's really sort of a shell game. They have the charge master price, which is this fictitious, price that nobody ever really pays, but that's what they put on the bill. And then the insurance company pretends that they give you a, 40 or 50% discount so that you'll say, wow, I'm sure glad I have that insurance company. In terms of how they charge, you brought up a good question. Some insurance companies charge that way. Some charge for percent of savings, but most of them charge a fee.
From treatment of sinusitis with balloon dilation to minimally invasive office procedures to correct snoring, Peachtree ENT Center offers state-of-the-art care. We also specialize in price transparency. You'll know the cost of our ENT services before they're rendered, whether you have a high deductible plan or no insurance at all. Make an appointment today to find out why Peachtree ENT Center is where patient care counts. Call 404-591-9100 or visit us at peachtreeentcenter.com.
My question was, these insurance companies seem to price things and try to tell the employer that their value is based on how much they save. Is there, in your opinion, a reason that's the reason why the costs are so high? And you mentioned that there was a charge master. Who makes up the charge master? Is it coming from the hospital? Is it coming from the physician's office? Who sets that initial high fee?
It's usually the hospitals. And I saw a comic once, which I think is probably appropriate. And the comic was of, a couple of monkeys with a dartboard, throwing darts and saying, "Hey, let's charge that."
That's pretty good.
And it was kind of funny, but the prices really are that random. I've seen people charge $100,000 for a knee replacement. The Medibid average price is under $19,000. So charging $100,000 is ridiculous. The average insurance company paid price is $35,000. So $100,000 is not related to anything. Now, the way the insurance companies charge for network access, there are usually a combination of any two of three fees. One is a fixed dollar amount, and it can range from $2 per employee per month to as high as $25, sometimes even $30 per employee per month. In addition, they usually charge an access fee. It can be, as you mentioned, a percentage of savings. It can also be a percentage of the procedure. Now, when they do it as a percentage of the procedure, it could be of the charged amount, it could be of the paid amount. There's no consistency. When they charge a percentage of savings, it's of that fictitious savings. Because, using round numbers, let's say a hospital bills $100,000 for a knee replacement, and then the insurance company takes a fictitious discount of 50% and then pays the other $50,000. Now, did they really save the patient $50,000? No, they didn't. They just had this, this game, this shell game where they have the charge master and then the allowable charges. So that wasn't actually really savings. So if anybody's charging a percent of savings versus the charge master, I think that can be, pretty deceptive.
Absolutely. And it sounds like a Wild West situation. Is there any regulation that is looking at this? I mean, what is the government doing? This is where I think they probably should step in to make sure that gouging isn't happening. Is there any entity that watches what's going on?
None. Well, there's a lot that watch what's going on. I dedicated a couple of chapters in my book called "Rigged: How Insurance Ruined Healthcare," just talking about this, the artificial PPO discounts and the charge master and things like that. The biggest thing that I have seen happen after Medibid started, a couple of companies started doing what's called reference-based pricing. We have 87 companies that we administer through Medibid that do reference-based pricing. Now, what that is the plan pays a reference price. In other words, there's no charge price and artificial discount. There's just a reference. Now, in the state of California, the California state employees, CalPERS, pays a reference-based price on probably half a dozen or so procedures, knee replacement, hip replacement, etc.
Mm-hmm.
And on knees and hips, I believe it's about $30,000 that they pay. So that's been around for many years. The state of North Carolina and the state of Montana just announced within the last 2 or 3 months that they would be going onto reference-based pricing for their state employees. North Carolina has 720,000 employees. Montana has 30,000 employees. And what they're doing is they're doing a multiple of Medicare. North Carolina, for example, I believe that what they chose is 177% of Medicare. So in other words, if Medicare would pay $10,000 for a procedure, their plan will pay $17,700. The multiple of Medicare is probably the most common reference used right now.
Mm-hmm.
Not that I necessarily think that Medicare has the magic formula on what things really cost, but it is a consistent reference. Most facilities and doctors and hospitals and ambulatory surgery centers have Medicare, prices for everything except for sometimes pediatric procedures. Because of course Medicare, as you know, it covers mostly seniors and disabled people, but not too many children. So, but for everything else, there is a Medicare rate. So if you do Medicare plus, 20%, 50%, 70%, that's a reasonable thing.
But still, I have to say, the Medicare rate is not based on reality either, frankly. But
correct.
It's not commensurate with running a business and staying open. But it's still not based on reality. Don't they bother to ask, like an independent physician, independent surgeon? They know what the cost of something is. Shouldn't it be based on what to me, instead of what the hospital is going to charge, which is totally fake, what the doctor says it should be? That would be a heck of a lot cheaper, don't you think?
Well, I believe it would be, Dr. George. I really do. However, when you talk to a stop-loss actuary or underwriter, they have to set the rates based on something concrete.
Mm-hmm.
And they know that 150% of Medicare, they know what the average price is going to be for a knee and a hip and heart valve and, like all these things. They know it, so they can predict fairly accurately. They used to have plans that were called indemnity plans that were based on usual and customary, or 80% of usual and customary. The problem is, how do you define that? Is that the charge price? Is it the paid price? And the paid price, both the charge and the paid price are artificial. So I agree with you that Medicare doesn't know that, but if you have some latitude, if you say the plan will pay up to, again, let's say 150% of Medicare, some providers will say, hey, you know what? I am so good at this that I can charge 80% of Medicare. Others will say I want 130, and some will say I want 200.
Right.
And the employee can go to any provider they want. If they want somebody that charges more than 150% of Medicare, they just pay the difference.
Okay.
And that works because a lot of these plans, they don't have big deductibles and big copays.
Mm-hmm. So
in essence, your copay is the difference in charges.
That seems a lot more, patient friendly from what you're describing. And it makes them consumers too, doesn't it?
Exactly. We had a client in the Seattle area with 185 people on their health plan. They were paying $2.3 million a year. We reduced their cost to $750,000 per year just by cutting out the middleman. And they used that savings of $1.5 million to invest in hiring more staff.
Mm-hmm. And
they built their business. They increased their sales. And now they have almost double the staff that they used to back then because they were wasting so much money on health care. When I talk to a company about what they're doing and how much it cuts into their profit, and I say, I ask them, how do you increase the profit of your company? They say, well, I could increase sales. Okay, if you increase sales, does 100% of every dollar go to the bottom line? No, it doesn't, because I have to pay staff, cost of materials, etc. Okay, what else can you do? Well, I can cut expenses. Okay, if you cut expenses, does it go to your bottom? Yes, 100%. Okay. So where are we going to cut costs? most companies in America, the biggest line item is payroll. The second biggest is very often healthcare. So cutting payroll means you're actually losing people, which potentially could cut into your sales and productivity. But if you cut healthcare costs, then you're just really cutting out waste. 57% of companies feel that there is a lot of waste in healthcare, but only 7% of companies really, do anything about it. And part of that is because the big insurance companies prohibit self-auditing.
What? Okay, hold on.
Yeah.
What is that? Go back over that one, please.
Okay. If you're dealing with one of the big insurance companies, the 5 big ones, very often they will have a clause in their administrative services agreement that says the employer may not contact providers and ask them what they billed us or what we paid for the treatment of their employees.
Wow.
If, that can only be done through us. So if you want to know anything, you have to ask us. You can't ask the provider how much of your money we paid them.
That's incredible.
It is.
I mean, that is
really
incredible. Talk about an unlevel playing field. So they get to say whatever they want, and they really are a closed gatekeeper.
Yep, absolutely.
And so the employer's paying them. And I have an example of this right now, where it's an ERISA plan. I did the surgery, and it's being administered by a commercial insurance company. I got the pre-cert, did the procedure, and the insurance company didn't pay me. And I'm now in limbo over a year now because the union that they're paying for the administrator, I can't seem to get them on the phone. They're not really accessible. They need to know that they're paying for a product and their member isn't getting served. But I'm stuck in limbo. I can't contact anybody, and I'm out of luck, and I'm not happy about it. But from what you're describing, no wonder it's a black hole that you have to talk to the insurance company. And the insurance company has its conflict of interest, right? Mm-hmm. They're not going to want to pay it out, even though it's not their money.
Yeah, exactly. And, but sometimes they charge the employer. They say, this employee went to, Dr. Smith and had, XYZ procedure done, and we paid him. And, the reason you can't contact Dr. Smith is he'll say, no, actually, they didn't pay me. They did a pre-cert, but then they, changed their mind. So, that has occurred too. And there's a lot of duplicate billing. Some is by mistake. Some is legitimately by mistake. I can't say for sure that all of it's by mistake. I just don't know. Mm-hmm. The other thing, there are a few things that really save money. When you're dealing with MediBid, for example, we have what's called bundled pricing, where they bundle the cost of the surgeon, the anesthesiologist, the facility fee, nights in the hospital. They put all into one package. So the Medicare rate for the facility fee might have a lot of excess in it, whereas the Medicare rate for the doctor's fee might be a little bit short. By bundling it all, the hospital administrator and physician together can say, hey, look, I think that, the Medicare would only pay me $1,200 for that. That's a little bit, that's a little bit low for an 8-hour surgery. I'd really like $2,000. Mm-hmm. And then the hospital says, yeah, they kind of pay us a little bit, too much. So we'll kind of trade off. So that can happen with bundled payments as well.
I see. I wonder how often that happens, though. I bet the hospital takes it all and doesn't give the surgeon anything. I mean, wow. On that note, we have to digest this. Let's take a break. You're listening to Medicine on Call.
Are you having problems with persistent bad breath, constant throat clearing, hoarseness, a cough that won't go away, a sore throat, or a feeling that something's always stuck in your throat? Why not find out what the problem is so it can be fixed? At Peachtree ENT Center, we believe in taking time to work with our patients as a team to get to the root of the problem. Make an appointment today to see why Peachtree ENT Center is where patient care counts. Call 404-591-9100 or visit us at peachtreeentcenter.com.
Welcome back to Medicine on Call. We're speaking with Mr. Ralph Weber, the CEO of MediBid, author, I think a healthcare futurist, actually, who's giving us the information about what really goes on behind the scenes with these employer-based plans. And these are called ERISA plans specifically, right? They're government regulated, are they not?
Correct. There are two kinds of health insurance in the U.S. There is a fully insured plan and a self-insured plan. A fully insured plan is governed by the state departments of insurance. A self-funded or self-insured plan is regulated federally under ERISA by the Department of Labor. 76% of American people that are covered by non-Medicare, Medicaid, VA, in other words, everything but the government programs, 76% of them are covered by a self-insured health plan. In a self-insured health plan, it's the employer's money that pays, not the insurance company money. They usually have stop-loss insurance to protect that money, but it is nonetheless employer money. That, in my opinion, the employer should have full transparency into how it's being spent. Mm-hmm. But often they don't.
And, they're writing the contract with these insurance companies. Do they, I would think if I were part of the financial services of an office, I'd want to know where my money's going. The fact that I'm paying perhaps a percentage of what you're supposedly saving me, you have to have full transparency to know exactly what they're actually paying out. And if they're not paying out and they're charging me for the discount, that has to be fraud, isn't it?
In my opinion, it is. Absolutely. I believe it is. There really isn't a lot of transparency in healthcare in the U.S. It's very, very unfortunate because if there was, I think a lot of things would be different. There are some companies that claim to add transparency, mm-hmm. and, they do a reasonable job. However, adding transparency alone doesn't cut costs. As a matter of fact, it can actually increase costs. I've talked to employers where they've added a transparency tool where the employee can say, okay, I need a knee replacement. My deductible is $5,000. Where am I going to go? Mm-hmm. And they see two doctors, Dr. Jones and Dr. Smith. Dr. Jones wants $30,000. And when I say Dr. Jones, I really mean the facility, the anesthesia, like the whole price, not just the surgeon, mm-hmm. Is going to be $30,000, whereas the other hospital with Dr. Smith in it might be $90,000. So most employees are going to say, hey, look, it's going to cost me the same $5,000 no matter where I go. I want the $90,000 provider, because most Americans, lacking more information, use the price as a proxy for quality. But we've done some studies that have shown that very often the exact opposite is true. And let me explain why. Let's take those two prices, $30,000 and $90,000. So let's say the one that charges $30,000 is a very experienced surgeon. He does 500 knee replacements a year. He's in and out in 25 minutes. If he runs into a complication, he's seen it 100 times that year alone. He's got no problem. He fixes it, bang. You're in and out of the operating room in 30 minutes. The inexperienced surgeon does one or two of these a year. He comes across a complication, he has to call another surgeon in. Even if he doesn't, it might take him 2 hours. Now, the cost of healthcare is broken down into a few components. There's the surgeon's fee, the anesthesiologist, the facility fee, and even the facility fee has two parts: time in the operating room and nights in the hospital. So if you're only under anesthesia for half an hour, you might not even need to stay overnight in the hospital. Whereas if you're under for 2 hours, number one, you've got more OR time, more anesthesia time, and those both bill by time. And possibly 1 or 2 nights in the hospital because you've been under anesthesia for so long. So the inexperienced surgeon can actually result in higher charges.
Wow. On that note, let's take a break. You're listening to Medicine on Call.
health insurance was the promise of Obamacare. But for many, the government mandate caused more problems than it solved. This is Dr. Elena George from Medicine on Call, and I want to tell you about a truly affordable alternative allowed under Obamacare, Liberty HealthShare. Liberty HealthShare bypasses doctor and hospital panels, giving you the freedom to choose. And with a maximum of $500 out of pocket per person and 100% coverage up to $1 million per year per occurrence, you can rest assured knowing you and your family are protected. Coverage starts as low as $107 per month and also includes dental, vision, pharmacy, and holistic care. Liberty HealthShare puts you back in charge of your health. Visit them online at libertyoncall.org. Again, for a true affordable alternative to Obamacare, visit libertyoncall.org or call toll-free 1-800-714-6993 today.
Welcome back to Medicine on Call. We're speaking with Mr. Ralph Weber, the author of a new book called Rigged, and everybody should go out and get that, because I think one of the things that people are really in the dark about, they don't have knowledge. They just, this whole healthcare system and the people who want to change it, they drive everything by emotion, but people don't know enough to be critical thinkers. They just know that they're paying a lot, they're not getting a lot, but they have no idea how to access the system and how to make the system work for them. And I think your book, one, is a treasure trove of information so that you can become informed. And then the second piece is the company that you run, MediBit, which is the solution to these problems. Now, you don't have to worry about having a health insurance plan to be a member of MediBit. You don't have to have anything but the will to find someone who can help you. And that's just distilling healthcare down to the doctor and the patient, which I really love. And I think that you provide a pressure that's going to exert force like a fulcrum against this system continuing to work the way it is. It can't continue the way it is. I mean, the Affordable Care Act now is hopefully gone, but it's not really. It's just in name only. But in practice, it's still there. Have you seen, since the advent of the Affordable Care Act, have you seen people who had the Affordable Care Act, had coverage, and because it was so expensive, couldn't use it and actually ended up using MediBit?
Yeah, I've seen a lot of people because it really increased costs for so many people. Mm-hmm. The passage of the ACA just increased costs for so many people that they got to the point that their costs were higher, their deductibles were higher, they're out of pocket. So they just said, I just can't afford this. And they ended up getting something that was just, in some cases, inadequate, or just staying uninsured and just paying the fine, which is sometimes cheaper than the coverage. One of the good things that has happened is the rise and the growth of the healthcare sharing ministries. Mm-hmm. Some of these healthcare sharing ministries are very, very efficient. And an employer still needs to meet certain mandates, which are still in effect, if you have more than 50 full-time equivalent employees. And one of the things that we do is we set them up so that they have a plan that, that is compatible with the ACA, that checks the box, that the employer is offering the health plan. It allows the employees to set up a health savings account to put pre-tax dollars in, and then it allows them to use healthcare sharing for the big procedures like the heart attacks, the cancer, strokes, knee replacements, etc.
Excellent. I mean, you kind of mix and match, but you're actually using the most efficient and cost-effective parts to mix and match. And, I think the mindset, too, is you don't want an insurance plan or anything to cover the first dollar, right? You're looking for coverage of the unforeseen expense, the catastrophic. Is that how people should look at it?
In many cases, yes. And I've got to be honest, I have softened my approach when it comes to that in recent years in some cases. And here's why. There's, I forget the name of the entity that did this study, but what they said is basically anybody that has a deductible, an annual deductible that's more than 5% of their annual salary, or out-of-pocket costs that are more than 10% of their salary, has an unaffordable health plan. They're paying too much. So when I talk to a CFO, he'll usually say, oh, yeah, we want a plan with $5,000 deductible and $6,000 out-of-pocket maximum. Well, according to that, the employee, to have a $5,000 deductible, the employee to be 5% should make $100,000. So a $5,000 deductible equates to an employee earning $100,000. I've heard that 42% of Americans, even though, and most of those have insurance, put off needed procedures because they can't afford the out-of-pocket costs. Recently, to make this even worse, some of the big insurance companies announced, and I'm paraphrasing here, but, they basically said, you know what, we just have some providers that just aren't in network. It's very, very possible that your anesthesiologist is not going to be in network and they're going to charge you extra. So we just can't control that.
Mm-hmm. And that happens a lot. And it's not even, they don't tell the people before they actually have the surgery. It doesn't only happen in the operating room these days, it's happening in the doctor's offices. So I've seen people who've gone in for colonoscopies, it's like an outpatient, basically an office-based procedure in some GI doctor's offices, but the anesthesiologist that goes there is not in network and the patient gets dinged with an anesthesia bill,
right,
even though it's an office-based procedure. Is there any way that we can make, I understand that there's all these moving parts, but why can't they be transparent in the sense that you're getting another bill before you do the thing so that you're not, caught, outside looking in with, I've got 3 other bills I didn't even know I was going to have. And people are outraged.
Right.
And they take it out on the doctor, actually, when that happens.
Oh, yeah, they do. There are some states which have passed legislation that says if you go to a hospital that's in network, every single provider in that hospital will be paid as if they are in network, whether they are or not.
Wow.
Okay, the patient is not going to be responsible. I don't know how many states. That's actually, as much as I disagree with so much legislation, that's actually one of the, pieces of legislation that to me actually makes sense.
Well, it's buyer beware. They don't do that for cars. They don't do that for anything else. They can't go and stick you with a bill after the fact, after you've negotiated, right? I mean, technically,
exactly.
A patient is negotiated for their insurance company to set a rate. They're going to pay what they say they're going to. I mean, this is as I'm sure any physician out there, this is so wrong on so many levels. The doctor and the patient play by the rules. I get a pre-cert. I ask to do it. It's medically necessary. The patient pays their premium, and then we both get the rug pulled out from under us after the fact, because the insurance company decides arbitrarily it's not medically necessary, it's not covered, after they pre-certed it, by the way. All right? So they said you could do it. You do it, and then they don't pay you.
Right.
That's horrible.
Mm-hmm.
I mean, you shouldn't have to fight like that.
Correct. And I sometimes wonder, when we deal with billing people, very often they don't, they're a separate company that does billing for, maybe a dozen or 2 doctors' offices.
Mm-hmm.
They, most doctors' offices don't do the billing themselves. They hire a company. Some of these companies just really have these incentives. And when I say doctors, I mean generically doctors and hospitals. I'm not picking on physicians because most physicians are very, very honest people that got into it for the right reason. But once you're dealing with a hospital and there's so many other moving parts, I wonder if there's an incentive for that billing company to get as much as possible. And, in many cases, they just feel that they're kind of, quote unquote, sticking it to the man, meaning the insurance company.
Right.
But sometimes it's the patient that has to pay, especially when there's a balanced bill that they weren't expecting.
Exactly. But I think the whole thing, honestly, could be avoided if we really started to look at the cost drivers. The pharmacy benefit management companies for big pharma, what are the GPOs for medical equipment and supplies? They are a problem. And I don't know when they started to exist, but I have a feeling that when they came online, that's when the explosion of prices happened. Do you have that feeling?
Right. Yeah, I sure do. And I would add the PPOs to that. The PBMs, the GPOs, and the PPOs are the 3 sort of middlemen. PPO, of course, for medical care, GPO for the devices and durable medical equipment, and then PBMs for the pharmaceutical drugs and stuff. And of course, the session that you and I were at in Washington D.C. That's a large part of that. What that was all about is cutting out the middleman.
Exactly, and the fact that the Congress has ingrained this in its law. that they could do this and that's not considered to be a crime. Who thought that? I mean, I just really want to know who introduced that legislation, because that was the end of affordable health care in the country. But, the thing that that really struck me in the conversation that we were at is that everybody is complicit, right? Because it's not just the PBMs and the rest of these guys, it's Congress too, because they're getting money back in terms of lobbying. So it's a complete circle. And you and I do not have the same power to go up there and give our peace of mind. They could care less about what we're saying, but we're the ones out there really trying to do our best to make healthcare affordable, take care of patients, really be a liaison and an advocate for the patient. These guys work against the patient 24/7, but they're given access, they're given carte blanche. We really how do you think we can expose this? I mean, what you're doing is working around it, which is awesome because you're providing a solution.
Right.
But how do we let people know this exists?
Well, it's really tough. It has to start with the employee. An individual employee or an individual self-employed person is very, very difficult to do anything about. But employers that have a self-insured health plan need to say, look, I want to see how you're spending my money. I've got it right. It's my money. I want to see it. And they need to look at their ASA or Administrative Services Agreement and see if there's a clause in it, like I mentioned in the first segment of this show, that says you cannot ask the provider how much they charge and how much they were paid. But they've got to make sure that these aren't in there. We always do a full data analytics when we're taking on a new client, and we have a healthcare waste index where we determine how much money is wasted, unnecessary. And I'm not talking about unnecessary procedures. I'm talking about duplicate billing. I'm talking about providers that have higher billed amounts. One client I did an analysis for. They had 900,000 claims. They had, I think they had about 80,000 employees, I think, if I'm not mistaken, maybe 250,000 total people when you include their dependents. They paid over $648 million in healthcare charges, or at least that's what they were charged, I should say. They paid about 30% less than that. But there was one charge, and there's a billing code. Most of the office, a doctor's office billing codes start with a 99. For example, the 99-213 is a level 3 office visit. There's a billing code that's 99199, and it's for a primary care physician, family doctor, miscellaneous charges. If you look up that code, the Medicare website says it's most often used for a no-show. And if a patient books an appointment, they don't call in 24 hours in advance. And as long as there's a written policy that all patients have signed, then that's legitimate. This client had one charge for $99,199. You will never guess how much that was. $28,000.
Oh, what? Oh my goodness.
Yeah.
Woo.
Yeah.
That's incredible.
$28,000 for a no-show for a family doctor.
I don't even have words for that. That's amazing. And this is why people, that one example is what hoses everybody else. On that note, let's take a break. On our last break, we're listening to Medicine on Call.
If you've tried taking over-the-counter medications, but still have problems with nasal congestion, recurrent sinus infections, sinus headaches, or a dry mouth when you wake up in the morning, why not fix the problem? From natural integrative treatment to minimally invasive surgery, Peachtree ENT Center will work with you to find the solution that works best for you. Call 404-591-9100 today to make an appointment, or visit us at PeachtreeENTCenter.com, because Peachtree ENT Center is where patient care counts. From treatment of sinusitis with balloon dilation to minimally invasive office procedures to correct snoring, Peachtree ENT Center offers state-of-the-art care. We also specialize in price transparency. You'll know the cost of our ENT services before they're rendered, whether you have a high deductible plan or no insurance at all. Make an appointment today to find out why Peachtree ENT Center is where patient care counts. Call 404-591-9100 or visit us at PeachtreeENTCenter.com.
Welcome back to Medicine on Call. Before the break, Mr. Weber was talking about, a really horrendous example of, I don't even know what to say about it. It's horrible. But let's start a positive train of thought here. If I'm a small employer, first of all, what are the size of employers that you generally work with when you're setting up their system, their medical system?
Most of my employers have between 50 and 500 employees. I would say that's probably, 70 to 80%. My largest one has 80,000. My smallest one has 10. But I've got everything in between. So I would say, 50 to 500 is the most, but really 25 to 5,000 is 98% of them.
Okay. And when you approach them, you'd mentioned that there's not one size fits all. That's another thing I really love about your business, is that I may want health sharing ministries for my employees, and somebody else may want something else. How do you? I know you offer everything. How do you what would be the thing that would make you run towards or recommend a health sharing ministry, for example? Because most people don't know about that, and they think it's too good to be true most of the time when you tell them about it. What is the thing that you say to an employer that educates them that this may be an option for them?
Right. Well, health sharing ministries are, they do ask health questions up front. So you have to be healthy. And some self-insured plans for smaller companies, not for larger companies, but for smaller companies, also ask health questions up front. So, and it costs more if you're a smoker or if you're not healthy or if you have a pre-existing condition. Now, the fully insured market, for small employers, there is no discrimination, but then everybody pays more because there are going to be some unhealthy people. Mm-hmm. In terms of the healthcare sharing ministries, that has just exploded. There are probably about 7 or 8, sort of the main ones that are out there. And then there are a few that have started since that aren't technically called a quote-unquote ministry. They're healthcare sharing entities that operate sometimes in the same way. Mm-hmm. All of those entities are usually much more transparent in terms of what's charged, what's paid, what doctors they can go to, et cetera. Most of them don't have a preferred provider network that restricts them only to people in network, which means that you can shop around. We work with 2 of those ministries where any kind of medical care that their members need, they just come to us and they say, I need a knee replacement, a colonoscopy, an MRI, and they get that through us. When they make a request, they can look at the quality, they can look at the price, they can look at the location, and the credentials of the surgeon to make that choice. So to get back to your question, when would I recommend it? I always recommend that's one of the options that they look at. Certainly not the only option, but one of the options. Some of the healthcare sharing ministries are, faith-based. So the employees have to sign a statement of faith for some of them, but not all of them. So it's always something that you should consider among other options.
Gotcha. And in terms of, like standalone indemnity plans like AFLAC or something like that, is that also a strategy that you recommend or not?
Yeah, absolutely. We usually recommend that with healthcare sharing as with any other plan that has a deductible. Mm-hmm. We've created plans that I was just talking to an employer today. It covers emergency room, inpatient, outpatient, doctor's visits, prescription drugs, like all of the quote-unquote things that we consider normal healthcare. There are some restrictions on them, in terms of how much it'll pay. Like, for example, what I said earlier, 150% of Medicare. And in some cases, there are restrictions in terms of how many events that you can have per year. So, but having said that, I've seen these things as low as sometimes $200 for a single employee per month. And that's with a $1,500 deductible and a health savings account.
Mm-hmm.
I've also had plans that have zero deductible, cover all the big stuff, sometimes as low as $250 to $275 per employee per month. And those kinds of plans are great for employers that don't have the margin to pay for a, fully insured, plan with the big insurance companies. Those are great alternatives. But because of the restrictions, sometimes employees like to have those kinds of products like, Assurity, Aflac, Colonial, et cetera,
mm-hmm.
to cover some of the gaps.
Got you. And with the changes in the administration, like being able, I don't know if it's actually been implemented yet, they've talked about it, but buying insurance across state lines, I know that the HSAs are still locked to the insurance companies, but I understand there's been a movement, hopefully a push, towards opening up the HSAs so that you can use them for whatever you want, whether that's insurance, whether that's health sharing ministries, whether that's direct primary care. Do you know anything about either of those two innovations?
Well, let's talk about buying insurance across state lines. It really doesn't do a whole lot. As we spoke about earlier, self-insured ERISA plans are federally, set up, so there is no state line in those kinds of plans at all.
Okay.
And that covers 76% of Americans. What's more important is buying medical care across state lines. Now, you mentioned a colonoscopy being done in a doctor's office. There are many states that allow that: Tennessee, Oregon, Georgia, et cetera, where you can have a level 2B sedative administered in a doctor's office. There are other states, such as Minnesota, Texas, to mention just two, where colonoscopy has to be done under general anesthesia in either an inpatient or an outpatient facility. And that greatly increases the costs. Our average cost for colonoscopy nationwide, our average is about $1,000. Our target price is $698 because in a lot of states, our average is $500-600.
Mm-hmm.
In some states, our average is $1,200 to $1,500. So getting medical care across state lines makes a whole lot of sense. So that, versus buying insurance across state lines. The other thing, I forget what was the other thing that you mentioned as a question?
Well, the HSAs, if we can, are they going to be unlocked?
Right. Okay. We already set up HSAs for employers that use healthcare sharing. Okay. It has to be part of an employer-sponsored plan. So we already do that right now. And it falls 100% within IRS regulations. That way they can, get an HSA contribution by their employer or by themselves, and save that money. So that's a really, really good thing to do. HSAs are one of the best, pre-tax, vehicles available,
mm-hmm. because
when you turn 65, you can use it the same way you can an IRA, take out the money.
Oh, that's cool.
Before age 65, you can only spend it on, quote unquote medical care, which is listed in section 213D of the Internal Revenue Code.
And when you take them out, you're going to be taxed on it after 65, right? Because it was pre-tax dollars. Is that how it would work?
Correct.
Okay.
Yeah, that's correct. Now, some of the things you can spend your HSA money is traveling for medical care. For example, if you're traveling from Atlanta to Houston or Atlanta to Costa Rica, then your travel costs, in some cases, if they're needed in order to get medical care, are deductible. I went a few years ago, and I traveled to get a crown done. And even after the travel and the accommodations, I still saved $1,200 versus getting it in Houston because I went overseas. So many of these expenses are tax deductible or can be covered by an HSA.
Wow. I mean, the choices are endless when you know what the bounds are. You can really mix and match and really make it your own. And we only have a few minutes left. I just want to make sure that people can find you. What's the best way to contact you? If I'm a small business owner, I need to contact you myself to make sure I can get my employees set up properly. But I mean, you handle everybody all over the country. Is that correct?
Yeah, exactly. And we've got people, in our office that deal with smaller companies, like with 5 or 10 employees. And we have specialists that work with the larger employees. A lot of brokers come to us and consultants, and they say, I have a client. They've got, whether it's 10 employees or 20,000. We help those brokers as well to put together the products and services that just make sense.
Mm-hmm.
Best way to reach us is, you can contact me personally, Ralph@medibid.com. Or you can call us at 888-855-6334.
That's awesome. And just for the patients, is there a membership fee to join MediBid, or do you just access the website? How does that work for a patient?
Normally it's through an employer group only. We did have an individual retail capability. However, that's temporarily disabled.
Okay.
What we had is, sometimes you have institutions that sort of, use that,
mm-hmm.
And that's not the intent. The intent is for individual patients. So we have to reconfigure that so that it's done properly and so that it serves the right people.
Okay.
It's a great alternative, and we're working on an individual membership.
Okay, awesome. Because I'm going to start. So let me know when it's active, so I can start referring people there. Because I think whoever has the pocketbook has the power, and it should be the patient and not the rest of this crew. Well, Ralph, the time goes so fast, Ralph. I have to have you come back and talk more specifically about your book, because where can they get it, by the way, Rigged?
Well, the Kindle version is on Amazon, and it's called Rigged: How Insurance Ruined Healthcare. I'm actually getting the paperback copy on Amazon. It should be up there shortly. I'm not sure exactly when, but right now it's available at howinsuranceruinedhealthcare.com. Until I get it uploaded to Amazon.
Excellent. Thank you so much for your time, Ralph. I know you're busy, but whenever you have a chance, I'd love to have you back on again.
Absolutely. I'd love to be. It's always a pleasure.
Same right here. Thank you for listening to Medicine on Call. You can reach me on Twitter as well as Facebook at Medicine on Call. Take care. Bye-bye.
Revolutionary talk for revolutionary times. Promoting peace, liberty, and prosperity around the clock. LibertyTalk.fm.